And Nastassia, are you going to turn on your camera or not?
I can't. My bandwidth does not support it, especially not with sharing the screen. So
No problem. You all have the bios and the photos, so you at least have an understanding in terms of what Nastassia looks like. She is an alumna of the program, right? Have you graduated yet?
yeah.
Yes.
Like 2 years ago.
I was looking, making sure, right? Living in Barbados, where I would much rather prefer to be today, is a medical doctor from the University of Guyana School of Medicine, has a master's in public health, London School of Hygiene and Tropical Medicine. And, in your spare time, picking up a PhD, right? Nastassia?
Yes. Yeah.
Just like the rest of us, always, trying to figure out the next level of education that we have to get. Has a passionate interest in HIV and in LGBT health and in decolonization of healthcare. So without further ado, I want to introduce you to one of our favorite alums who has a bit of information to share with you all.
Thank you, Kat. Hi, everybody. So I'm gonna try and share my screen. Oh, host disabled participant screen sharing.
That's okay. I'm going to make you a host for this, okay? Let me figure out how to do that.
Steve might be host now because when Steve came in, it flashed.
Yeah,
the thing.
he made
So
me
it might have to
host.
be Steve that makes her host.
Steve, can you make Nastassia host?
I think when I came in, it grabbed it back.
It
so
did.
Nastassia, I'm going to make you
Grab the power.
He grabbed the power. Figure.
I'm going to make
Typical
you the
man.
host.
Patriarchy.
By the way, we should test out the private chat. We may need to start the meeting again, which we'll have to do after the next long break. But we think we have the chat link thing fixed. So
Great.
there you go. You're good.
You should be seeing my screen. Awesome.
We are.
So great. So unfortunately, I can't expand it either. I have a lot of logistical issues. I apologize. But today I'll be presenting on LGBTQ plus health and practice. Kat gave a lovely introduction. And our objectives, real quick, if I can only change the slide. We'll go through why there are disparities in healthcare. We'll recap the healthcare needs by subgroup under the LGBTQ plus umbrella. We'll look at some hopeful news and then some tips or guidance on improving care in the clinical setting. I saw the profiles of the students, and we have quite a few of you who would have either worked in clinical settings or are working, and we'll end off with some key takeaways. And that's a picture of me looking extremely excited because I was just celebrating my birthday. And yeah, I thought I'd share with you since I can't share the screen. I like to start off all presentations on this subject with this map, which reminds us that sexual and gender diversity extends back through time as long as humans have existed, and span the globe. And then European colonization came along and imposed the hierarchies and the binaries that we are used to today. So when you see maps about legal issues, keep in the back of mind why those legal issues are now there today and who imposed them in the first place. So to get started on what are the health needs, or why are there health disparities amongst LGBTQ plus people? So they stem from, you can go from the familiar to some of you, micro, meso, macro level, or individual to community to societal level, at a more individual level, but they're all interconnected. Healthcare providers have discriminatory or negative attitudes and practices. They also lack knowledge. So that dissuades people from seeking healthcare, or they not necessarily might have had those experiences themselves, but they hear from other people and that also decreases their access. There is, of course, societal discrimination and stigmatization, and this occurs within the healthcare setting, not only from providers, but also from auxiliary staff. In Guyana, that's something that we found a lot, that sometimes you get a lot of feedback from the patient that, oh, the doctor is nice, but when I go in, the guard at the healthcare center or clinic, you know, gives me these dirty looks, asks me why I'm wearing this, you know, make stereotypical remarks, negative remarks. So it's an all wrong discrimination and stigmatization in the setting. They lack social support. There's also, again, more the individual level, internalized homophobia, but that also relates to the external level, like why is there internalized homophobia, right? And minority stress. I want to say a little bit about minority stress that some of you might already be familiar with. The minority stress theory was developed by Ilan Mayer, and it defines minority stress as an excess social stress experienced by members of historically marginalized groups. Importantly, it's not the identity itself that is stressful. Rather, it's society's response to these that perpetuates the stigma and creates stressful experiences for people holding these identities. The model captures the way in which various factors, including proximal and distal stressors, work. The proximal minority stressors refer to internal perceptions and responses to negative external experiences based on self-stigma, such as internalized homophobia. The distal stressors are external stressors brought about by society, such as harassment and or discrimination, and include microaggressions in various places such as schools, workplace, housing, and healthcare environments. These stressful social situations are associated with a greater prevalence of depression, anxiety, substance use disorders, suicide, chronic health conditions, and overall poor physical health. It's not just, so this theory kind of ties everything together that I would have just said. And it's not just a theory. They have found that there's actual direct influence on the physiology of people who experience minority stress. So there's actually greater inflammatory biomarkers, a greater increase of stress hormones that result in these adverse health outcomes. And a note here, obviously, there is a need to take into consideration the intersectional nature of minority stress, because persons might not only obviously experience this because of their sexual orientation or gender identity, but also because of other factors, so such as their ethnicity or their an experience of disabilities, obviously sexism as well. So definitely consider intersectional nature when you're looking at minority stress. And there's also a lack of preventative care, which is kind of like a self-perpetuating cycle, because it goes back to above all the things that make persons not go in for the preventative care, but also, especially in the US, where there's not universal health care, there are issues of insurance that prevent persons in the community from not accessing preventative care, especially if they're not, especially amongst trans persons who aren't necessarily in employment situations where they can get insurance. Most of what I'm going to talk about today applies to adults, but it's very important to note that LGBTQ plus youth are more at risk for bullying, depression, anxiety, suicide, and homelessness. So what are the healthcare considerations for lesbians? One of the things we need to consider is tobacco, drug, and alcohol use. Lesbians use tobacco at higher rates than straight women. They are also more prone to heavy drinking and binge drinking, as well as some drugs like marijuana. This may be obviously a way of coping with stress from homophobia, sexism, or discrimination. And the same risk factors for abuse and dependence, such as past abuse, genetics, family history, self-medication for pain, etc., apply just like with cisgender heterosexual women. Sexual minority women face the additional unique risk factors such as prejudice or coming out, and they may then encounter issues trying to access treatment for their overuse or abuse of tobacco, drug, and alcohol. So it's important to realize that while screening is done here, there are other concurrent issues apart from sexuality that need to be addressed with these patients. Lesbians are also more likely to be overweight or obese than straight women, and this puts them at increased risk of heart disease, cancers, and premature death. Dealing with discrimination can cause chronic stress, as we've already explored. Lesbians experience more stress than heterosexual women during their teenage years. They also experience more suicidal ideation. But studies have been inconclusive on whether there are a greater incidence of anxiety and depression. They found that there is no difference between lesbians and heterosexual women if the lesbians are out. You have to consider IPV. Around 50% of sexual minority women in the US have experienced physical or psychological intimate partner violence, which is IPV. Cancers are a consideration because lesbians are more likely to have risk factors for certain cancers like breast cancer. And the risk factors there would be never having children, having a high BMI, using alcohol, or smoking. They're also less likely to be screened, which means they're less likely to be diagnosed early when the disease is more curable. Smoking also increases the risk of cervical, lung, colon, stomach, and bladder cancer. The high BMI and nulliparity or not having children increases the risk of ovarian and endometrial cancers. Cardiovascular health, as you know, cardiovascular issues are the leading cause of death in women, and lesbians may be at greater risk of heart disease due to tobacco use, obesity, and depression. And finally, well, not finally, you also need to consider fertility services and parenting. There are more options available to lesbians than in the past, and they do have more options than cis men, but there's still unique clinical and legal issues to maneuver when it comes to fertility services and parenting, especially sometimes they want to become parents at more advanced ages, and then you have to consider legal issues around parenting. Finally, we consider STIs and sexual health screenings. This is not to put that on the list down because there's a misconception that because you're a lesbian, you're not vulnerable to, STIs. And this is actually a copy of a pamphlet I did for my lesbian health class with Kat, and I found it so useful. We've actually distributed this through a local LGBTQ organization that only focuses on women, and it's been received very well. But it really says that it highlights the common STIs amongst lesbians, but also bisexual women. And bacterial vaginosis is the most common STI in lesbians. There's also considerations for HPV, trichomoniasis, gonorrhea and chlamydia, thrush or yeast infection. And I did make sure to put HIV on there because while the risk is thought to be almost negligible between women who have sex with women, you have to consider that there is a risk if there's fingering, fisting, oral sex, and sharing sex toys. It also has some little pointers on there how to have safer sex and consider lube, and the fact that you might still need contraception depending on if your partner, is trans, and they can still get you pregnant. All right, so let's move on to considerations for gay men's health. Again, starting with tobacco, drug, and alcohol use, there are high rates of alcohol dependence and abuse in gay men than in straight men. Recent studies seem to support the notion that gay men use tobacco at higher rates, reaching nearly 50% in several studies. Obviously, this leads to health problems like lung diseases, heart disease, high blood pressure, and a whole host of other things. Substance use is also higher, and these include a range of substances ranging from poppers to marijuana, ecstasy, and amphetamines. I would like to get some feedback on maybe we can have a discussion then, because you might have recalled the FDA recently issued a statement about discontinuing poppers. And it was a very interesting conversation about that online and how the FDA reached that conclusion. All gay men should be screened for and offered culturally sensitive prevention and cessation programs for these substances. Next consideration is body image. Problems with body image are more common among gay men than their straight counterparts, and they're more likely to experience an eating disorder, such as bulimia or anorexia. And substances such as anabolic steroids and certain supplements can also adversely affect their health. At the other end of the spectrum, overweight and obesity are also problems that can affect this population, and obviously the resultant health issues that come from that. STIs and sexual health, important to consider in gay men, HIV and screenings. These occur at a high rate, and the STI infections include syphilis, gonorrhea, chlamydia, pubic lice. In Barbados in 2012, there was an outbreak of syphilis amongst men who have sex with men, and that has never returned to baseline until now. That is the most commonly STI that we see amongst men here. There's also considerations for HIV, hepatitis A, B, or C, and HPV. Obviously, safe sex. Since the HIV epidemic started, gay men have been very good about having safe sex. Now we have additional options of PrEP. And you also have to consider, yes, PrEP is really taken off in the US, not so much in other parts of the world. So that's something we have to work on. But even within the US, there is a disproportionate access issue with men, Black men or men of color who don't access PrEP as much as their white counterparts. So that is something to also consider when you see your patients, and address what are their barriers and challenges to not accessing it. So screening for STIs for gay men is annually or more often, 3 to 6 months, if they have multiple or casual partners. Note on HPV, remember HPV causes anal and genital warts, but they can also increase anal cancers and penile and throat cancers. So you can actually get the HPV vaccination. I know the CDC recommends it for men, gay men up to 26 years, but in the UK, you can actually get it up to 45 years. So counsel your patients on that. And just a note on why, because this is obviously a common stigmatization issue that, oh, gay men are more likely to have HIV. There's a reason why that is. There are some biological reasons, 2 main biological reasons, we could call it biological. Obviously, receptive anal sex is 18 times more risky for HIV acquisition. But also gay men tend to have a higher number of lifetime sexual partners and have a higher prevalence in their sexual network. More importantly, homophobia and stigma and discrimination, lack of access to services prevents them from getting tested regularly, accessing preventative services and also treatment. Next issue, vaccinations. Obviously, you would want to vaccinate for hepatitis A and B, and we spoke about the HPV vaccination, and safe sex is effective at reducing the risk for hepatitis C. Depression and mental health are issues among gay men. It appears to affect them at a higher rate than the general population. The issue may be more severe for those who remain in the closet and who don't have adequate social support. Adolescents and young adults are at particularly high rate of suicide because of these concerns. So make sure you screen your gay male patients. IPV is also an issue in gay men. It's associated with depression, drug use, sexually risky behavior, and HIV seropositivity. Around 30% of sexual minority men in the US have experienced physical or psychological IPV. Remind your gay patients to screen for prostate, testicular, or colon cancer. All gay men should undergo these screenings routinely as for the general population, because alcohol and smoking increase colon cancer risk, as well as lung cancer risk. Fertility services and parenting are also a consideration for gay men. They have less options than lesbians, but they still have surrogacy, adoption, and can freeze their sperm as well if they desire biological children. We move on to the bi+ population. So BIPOC people can be anyone with a non-monosexual orientation, and they are the largest group in the umbrella, the LGBTQ plus umbrella. But they are also the most invisible group and the most, what's the word, forgotten group. They receive less research into their issues, less funding of research into their issues versus lesbian and gay people. Invisibility is probably the number one consideration for bi people. They undergo bi erasure, and this affects their quality of care because, for like a bi woman in a relationship with a woman, may still have sex with men, but will not be offered considerations about contraception, etc. They endure double discrimination, which is discrimination from both heterosexual and the queer community. They constantly need to come out, and this leads to isolation and loneliness, which affects their mental health. Bi plus people experience a unique minority stress related to being bisexual, such as negative stereotypes about what it means to be bisexual, and bias against lesbian and gay individuals. While bias against lesbian or gay individuals is generally viewed as having a single dimension, the bias against bisexual individuals also include negative attitudes as well as stereotype-based bias, which portrays them as illegitimate and unstable. These unique forms of minority stress can be harmful for their health. They also experience constant microaggressions and high rates of victimization. It's really interesting that on mental health, substance use, everything, bi plus people actually experience higher rates of all of them compared to their monosexual counterparts. STIs are increased. There's increased risk of STIs in bi plus men because they have more risky sexual behavior compared to gay men, such as earlier sexual debut and more sexual partners, condomless sex, and substance use before sex. They're also less likely to get tested for HIV compared to gay men. Bi women also have an increased risk of STIs. They have higher rates compared to lesbian women, and higher rates of teen pregnancy. In regards to mental health, they have higher rates of mood and anxiety disorders, higher rates of depression, and of lifetime suicidality compared to both heterosexuals and gay or lesbian women. Several studies have showed that bisexual individuals are generally at increased risk for substance use disorders compared to monosexual individuals. This includes drinking, weed, and other drugs. Women who are bi plus may have poor health-related quality of life because they're at increased risk for diabetes and hypertension relative to lesbian women, while bi plus men may have high cholesterol, high blood pressure, and cardiovascular disease. Obesity also occurs more commonly in both bi men and women. And interestingly, one study also found to have a higher incidence of stomach ulcers and gastritis. This might be from the constant stress. All right, the final group under the umbrella are trans people. So transgender health considerations, the most important one, and it kind of leads to all the others that influences all the others as well, is access to services, as I would have alluded to earlier, because of lack of insurance, lack of employment or formal employment, especially discriminatory attitudes towards trans people amongst society and in healthcare settings. They just don't access the services and they can't find a doctor who is knowledgeable about trans health. Their second most important consideration for a lot of trans people, not all, because trans people don't necessarily need to alter their bodies in any way to be trans, is hormone therapy and getting it. Again, a lot of doctors told hormone therapy isn't really it. The World Professional Association for Trans Health says that general practitioners or primary care physicians are the best persons to give or prescribe hormone therapy. Yet still, a lot of people think that they need, specialized care, that you need an endocrinologist to really give hormone therapy. And people, especially in non-large cities, trans people can't find a doctor who's willing to give them hormone therapy, when really this should be part of the curriculum for any medical student so that any family care, physician can provide it. You only need specialist intervention if they're like specialized considerations. So if the person has other endocrinological stuff that they would normally need an endocrinologist for. So it's really a movement. I've been trying to do that here to try and get GPs to realize that they should be the ones providing hormones. There's also the mental health gatekeeping aspect of it, because back in the day, you need to have to get a psychiatrist or a psychologist to sign off on you getting hormone therapy. That is no longer the case. The patient can give informed consent. Some people still, so like I still like a psychologist to do I would say a consultation. It's not them signing off. It's them saying that, you know, I've spoken to this person and whatever mental health issues they have are well controlled, or we will get them well controlled, and they will work with them on as needed, or they don't need any work. This person is just, great. So I do that especially here because there's no legislation and there's no guidelines about hormone therapy here. But in the US, where there are, guidelines and more specific recommendations you can follow, it's not even necessary to really get a mental health professional to sign off on it. All right, that was a rant, sorry. In regards to cancer risk, basically it's easy. If you got it, check it. So some people get all twisted about what should I check for my trans female patient, trans woman patient, what do I do? But if the person still has the body part, just check it as you would for any other person, any other patient. Maybe consider for persons who are on feminizing hormones, obviously, if they still have a prostate, screen at. With regards to breast cancer, it's unsure whether feminizing hormones increase the risk of breast cancer. So you're better off maybe doing screening 2 to 3 years after starting the hormones, depending on their risk profile as well, like, if they have a family history of breast cancer. Persons who are on masculinizing hormones, they don't know if there's an increased risk of ovarian cancer, so they recommend they have periodic pelvic exams and still have pap smears if they have a cervix. Masculinizing hormones don't look like if they increase the risk of breast cancer, but there's not a lot of research on it. So obviously still screen breasts if they are present. With regards to STIs, trans women are disproportionately affected by HIV. The pooled HIV prevalence worldwide for trans women is 19.1%. There's scarce data on trans men's incidences, but it's likely less, but still maybe more than the general population. This is because the trans women experience stigmatization and institutional discrimination. And again, they're doing survival sex work and increased risky sexual behavior because of the stigmatization and discrimination that they experience early on. With regards to alcohol, tobacco, and substance use, trans people are at elevated risk for developing problematic substance use. They have high rates of alcohol use, marijuana, and other illicit drugs. Also, non-medical use of prescription drugs. Again, associated with transphobia, gender discrimination, and religious abuse. No surprise, but trans people experience high rates of depression, self-harm, and suicidal ideation. Of note, trans people are also at increased risk for heart attack or stroke. It might be from the hormone use, especially if they're using hormones without medical supervision and using higher doses than they should, but also because of cigarette smoking, being overweight, high blood pressure, and diabetes. Trans women sometimes fear that their provider may make them stop estrogen if they develop heart trouble, and so they don't report feelings or symptoms of early onset heart issues like chest pain or trouble breathing. And finally, trans people experience violence, not only intimate partner violence, but violence from society in general. And this is a consideration when you interact with them because they would have experienced violence from healthcare providers as well. All right, so what's the hopeful news? Since the 70s, which is when they would have done some of the first set of surveys and physician attitudes, this has improved. especially in the US, but there's still negative attitudes and biases. Personal characteristics such as age and sex have been found to influence physician attitudes, such that older persons and men are more likely to exhibit negative attitudes. So hopefully as the younger generation gets into healthcare positions, those attitudes will also improve even more. Medical school curricula. So this has also improved. And it's been shown that medical students with greater LGBTQ plus clinical experience provide higher quality care to their patients. However, medical education in LGBTQ plus healthcare is often limited or absent, especially outside of global North countries, which severely restricts the number of physicians with competence in LGBTQ plus healthcare. One study of US and Canadian medical schools showed that the median time spent on LGBTQ plus healthcare was only 5 hours. Additionally, 33% of medical schools failed to cover any LGBTQ plus content during the clinical years, and 7% lacked any LGBTQ plus training during the preclinical years. When this is broken down according to the type of content, trans content is extremely limited as well. So even within that little bit of pie, the 5 hours, there's still even less devoted to trans health issues. I want to talk a little bit about my capstone project, which actually looked at these issues in the Guyanese context. So it's been published, it's online, International Journal of Sexual Health, and it's called Providing Care to LGBT Patients in Guyana, an Assessment of Medical Providers' Knowledge, Attitudes, and Readiness to Learn. It was a mixed method style study. It was 90 physicians were surveyed, and 8 physicians were interviewed qualitatively. It found that similar to the rest of the world, knowledge was low to average. And while most doctors surveyed correctly identified LGBTQ plus patients as having unique health needs, the interviews, which is why mixed methods is so great, the interviews showed that there was a general lack of knowledge on what these unique health needs and disparities were. Both types of data confirm that doctors rarely ask patients about SOGI, which are sexual orientation and gender identity, which is in keeping with findings in the rest of the world. They tend to only focus on sexual health and STIs, which a lot of doctors do when they find out that their patients are LGBTQ+. However, interestingly, both in Guyana and Barbados, which is unlike the global north, when doctors find out that their patients are lesbian or bisexual, they don't decide to not offer them pap smears. They think that they still need to be screened for cervical cancer, which is great. Knowing an LGBTQ plus person and working in the public sector are associated with higher knowledge score. Mirroring the trend in studies, clinical attitudes from the surveys as well as interviews were generally non-discriminatory, although almost half of the surveyed doctors thought they had more unpleasant experiences with LGBT patients versus heterosexual patients. So this was really interesting. There was no follow-up question on this statement, but in the interviews, it came across that sometimes doctors thought that their gay patients were dramatic or noisy and made a scene in the waiting area. So this might be connected to that. Many doctors also thought LGBTQ plus patients were more likely to be infected with or have an STI. And this obviously is a broad generalization that is incorrect. This study did not find any correlation between the demographic characteristics and attitudes or knowledge, although it did find that persons who thought doctors should behave differently with LGBT patients have had a lower score. Interestingly, similar to lots of other places, almost no one had any training in LGBT health during medical school. And even though the majority of doctors are neutral or comfortable addressing the healthcare needs of LGBTQ plus patients, perhaps recognizing that they had these knowledge deficits, they were almost all willing to attend educational sessions on the topic. Of course, a small but significant proportion still didn't want to, and this might be because of personal biases, discomfort with discussing sexuality, and not understanding the relevance of sexual orientation and gender identity to their clinical practice or specialty. So I think the study concluded that knowledge on LGBT health amongst the physicians in Guyana was moderate and could be bolstered by training, and attitudes were generally non-discriminatory, but there was confusion in terminologies, and differentiation between sexual orientation and gender identity needed to be addressed. So what we've done in our little ways, this is bringing it to a Caribbean context in this instance, we've been doing training for healthcare providers. Since COVID, this has been mostly on webinars, but we've also done them in person pre-COVID. I've done some medical school sessions in Guyana, just going over the basics and how they can improve their clinical care and how they can, better interact with patients in general as well, not just their LGBTQ plus patients. And I'm so pleased. These were first year students and they were so receptive to it. And it was really pleasing to see that they didn't have any of the big biases and they were really concerned as to how they can really do this very well. Of course, they were eager first-year medical students, but it was very promising. In Guyana, they've also had health centers being certified after they did trainings with their staff. And in Barbados, since we've done 2 studies looking at, well, one was at GP attitudes towards LGBTQ plus patients, and the other was on body image in lesbian and bisexual women. The family medicine residency program here has been making steps into improving their curriculum, and they've actually incorporated in their exams, which is how you make sure that the doctors remember this stuff. In their exams, they've started examining on competent care, which is great. And also to add to the hopeful news, there's not, because everything so far I've said has been negative, right? And even though there's not a lot of research that's been done, and we definitely need more of it in the global South, but in spite of the oppression and the disparities, studies have showed that LGBTQ plus people are socially intelligent. The experience of being a sexual or gender minority actually fosters social and emotional intelligence. So this generally results in the ability to read a room and evaluate the correct social response. And while these motivations are symptoms of a broader enforced intolerance in the culture, they've given way to an adaptive social skill that cisgendered heterosexual people are less likely to possess. LGBTQ plus people are also more authentic. They feel less pressure to conform to society-defined roles and narratives. They are resilient. When LGBTQ plus individuals are actively involved as change agents, they're better insulated against the damage wrought by anti-LGBTQ plus politics. The 5 resilience factors that help in coping with adversity are social support, connection with the LGBTQ plus community, emotional coping, self-acceptance, and positive reframing. I would love to be able to do some more research on that in the Global South context, because everything so far in resilience is very Global North. Because LGBTQ plus individuals are more likely to face identity-related discrimination and accompanying emotional hardships, they often have no choice but to develop this resilience. LGBTQ plus people are highly creative, not just the traditional use of the word creative, and I see we have a session in creativity during the residency, but also in creating their stories and their narratives and who they choose to form family and social circles with. So to end off, well, we're moving into the final part of this presentation, and I would just like to give you some recommendations, guidelines on creating a more inclusive environment and interacting with your LGBTQ plus patients. So with regards to creating an inclusive environment, you might want to look at your visual cues. So some options for this are having a non-discriminatory statement, having brochures in the waiting area, having a rainbow pin flag. And interestingly here, and I think that might apply to some rural areas in the US as well, people have said they don't want to actually go to offices that are very out and proud rainbow, because then they said they will be stigmatized as being LGBTQ. So you might want to do something that is more nuanced. and actually maybe have literature or posters from from HIV organizations to LGBTQ plus organizations that people will only see when they rifle through. Everything helps, every little bit helps to show the support. I've seen some doctors here on their social media is where they advertise that they are LGBTQ plus friendly. So they might not have, and this will obviously, more cater to the younger population, so that in their office, you might not see a lot of the visual cues, but if you would have gotten to them through social media, you see that they would have advertised this. Unisex bathrooms, obviously a good way to create inclusivity. And it doesn't have to even get to advertising unisex bathrooms. Just put bathrooms on the as the notice on the bathrooms. Don't specify what sort of bathroom or who should be using this bathroom. Just put bathrooms. And there you go, unisex bathrooms. Intake forms, you might want to consider adapting them. Instead of putting things like marital status, use instead relationship status. Have an option for partner, and obviously have an option for people's personal pronouns, their non-legal name, and in terms of gender, give them a broad variety of options, or let them just write it in. All of this depending on the amount of autonomy you have in your clinical setting. So you might be great and advocate and culturally competent, but if the staff isn't on board, and again, by the time the patient gets to you, the receptionist would have already given them stink eye, and asked invasive questions, and so all the good you would do as a doctor can get derailed by that. So make sure that there's staff training concurrently occurring with what you're trying to do in the office. With regards to clinical skills and interactions, as with all patients, empathy, open-mindedness, and being non-judgmental are foremost. Don't assume literacy or language capacity with patients. Sometimes I kind of ask, I ask patients to fill out their intake form, and if I see them just hesitating, I would be like, well, would you like me to, I could just fill this out for you, I could just read you the questions, and then they'd be like, yeah. And that's a way to kind of get around that. Use gender neutral language, so words such as partner, significant other. Mirror the language that the patient uses. So if they refer to a person as their wife, or if they use words as gay, that comes with a little bit of a caveat though. So sometimes there are some slurs that patients would use that only persons in the community should really be using, and you who are not in the community should not be using it. So you might want to avoid using those words still. Clarify unfamiliar terms or behaviors, and then repeat what your understanding of it is to avoid miscommunication. When discussing safer sex and sexual practices, don't presume heterosexuality or use discriminatory language. That seems explanatory. When talking with trans people, avoid probing. It's amazing how, because this might be the first trans patient you've ever come into contact with, and you're just so interested to find out, and you might think you're doing it with good intentions, hopefully, but asking unnecessary questions is probing and will make the patient uncomfortable. What would help is telling them why you need the information, and only ask clinically necessary information. You definitely have to build rapport and trust with trans patients, especially because they would have had traumatic medical encounters. I don't do genital examination or even upper chest examination on my trans patients the first time I see them, because a lot of times they're just very reserved. When they come in to see you the first time, they don't know what to think and how to suss you out. So you want to build that, and then maybe the second or third visit, then is when, but you obviously ask questions. You take history. We don't necessarily do that part of the physical examination. Use chosen names and pronouns. If you make a mistake, just apologize and aim to improve next time. Don't be afraid to tell the patient of your inexperience, but don't use it as a crutch. So it's okay if the first time you're like, oh, well, sorry, I'm kind of new at this, but I'm willing to learn. The third time you see the patient, you still using that excuse is not really good. It's on you to educate yourself, and to not the patient to educate you necessarily. So after you would have had that experience, you should go home and do your homework. Really important for LGBTQ plus patients is ensuring confidentiality. I know this is not as much an issue in the US, especially since you have HIPAA laws and all that, but it's definitely an issue here, a very big issue, and it prevents access and preventative care. And finally, lastly, but not least, your face and body language are very important, because you might be saying all the right things, but your face and body language is not following along. So that's it. What are our takeaway points? LGBTQ plus people experience healthcare disparities. Progress is being made, but much more remains to be done. You, by providing sensitive, competent care, eliminate one of the reasons for those disparities. LGBTQ plus people are more than just their sexual health. Use neutral terms in clinical encounters and do not assume heterosexuality. Again, empathy, open-mindedness, and being non-judgmental are foremost. Thank you. I'm going to stop sharing.
Okay, any questions?
All right, wait, I'm just reading the chat here, and I see Joe said the new ACIP recommendations that HPV vaccination should be considered for any adults through 45, 27 to 45. That's great. CDC really needs to update theirs.
I really appreciated that you included bacterial vaginosis and STIs for women who have sex with women. I think it's important to understand that. I think many gynecologists, many primary care providers don't realize that it is a vaginal condition that can be transferred to another vagina. And it is definitely important, especially because bacterial vaginosis is so difficult to get under control once it's present. So I think it's really important to have that sensitivity with our patients, our female patients who have sex with women. The other thing I think is also important to note is for trans men for whom their cervix has been removed, though the vast majority of them no longer need cancer screening, if they've had any dysplastic cells on their cervix, they will continue to need vaginal cuff cancer screening for the next 25 years. And that's something that many folks don't realize. And I think we're failing our trans patients, trans male patients who have a history of cervical cancer or cervical dysplasia. So I just wanted to note that.
Thank you. That's excellent. I agree with the first point. A lot of doctors don't know about the STI risk for women who have sex with women, and I did not know about the dysplastic changes still continuing screening. I mean, obviously, I knew that if the cervix has been removed, and it was before, you don't need to continue pap smears, but I did not know that. So thank you. Yeah. And that's also why it's really important to continue our own education as well too. Any questions, other comments?
It always depresses the hell out of me. We go from fisting and, lube to here's the list of everything bad that can happen. And I'd like to see more studies about resiliency, about positive life experiences, about how we survive all these negatives. And it's not just in terms of the lesbian health outcomes, but for all LGBT health outcomes.
I agree. And this is why the last time I gave this, that was the feedback. So I said, this time, let me make sure I include some stuff on resilience. But the the fact is that there's not a lot of studies on resilience and how, we've been overcoming these things. So we definitely need more studies on them. But obviously at the same time too, it's also important because, yeah, we shouldn't be having to become stronger. What was the thing that it happened to you, so it made you stronger? We shouldn't be having to do that. The negatives and the societal attitudes need to be changed. That's just
Agreed.
the bottom.
Other thoughts or questions?
Jared, there's a really good book about discovering joy in sex for trans individuals. Ooh, I attended a training by this presenter. That looks amazing.
I've been buying a whole bunch of lesbian joy sex books for the young lesbians in my life who
Nice.
are living in the house at the moment. I have 3 kids in the house at the moment.
Sex clinical approaches. All right. I hope I can, I need to write that down. I'm gonna forget this.
Okay, we actually will
Rutledge
save.
publishes great queer stuff, Jared.
What's that?
I was just saying that like Rutledge publishes such great queer stuff. I love that.
Oh yeah, yeah. And the person who wrote that book is a mental health counselor and received their PhD in French literature and language. So the perspective that they write from is really neat because it sort of challenges like a lot of the cultural norms and it's more about just what brings people joy with their new embodied experience as they affirm their gender identity. And I just think it was a really cool presentation and book to read.
Yeah.
So is this book written, the targeted audience, is it more for medical professionals or for general, uninitiated audience? I'm asking because I saw earlier 2 Chinese lesbians, one published a book teaching lesbian safe sex and the joy of sex, and they actually created this Facebook forum. They just chatted out there. So I was wondering if there's an effective way of just disseminating the knowledge to general audience. I wonder if you all have experiences doing this.
Trans bodies, trans selves, just like the original. Funny enough, I don't remember the name of the original book off the top of my head, but that is a really good book for lay audiences. I highly recommend that one. Does anyone know the original book that I'm talking about?
Our Bodies, Ourselves?
Yes.
The one that was written by women back in the
Yes.
1970s? Yes.
Yes.
The Boston Women's Health Collective.
Yeah.
Yes. Used to be on Friday nights.
I just read the reviews of this book. And one of the reviews reads that it's an essential guidebook for every medical provider, therapist, social worker, teacher, and helping professional, whether they focus on sexuality and gender or not. So I think any of these books that are going to give us a little bit more information, even if it were for our trans patients, us reading them, validating that they're good resources to give our patients would be beneficial to any healthcare provider.
Agreed.
I literally went and grabbed a bunch of them that I use, right? So I'm putting this in the chat, the lesbian sex book, the lesbian passion book. A lot of these do not include trans resources, so you might want to check on it. This is the Belly Dancing as Natural Childbirth, Living Our Visions for Building a Feminist Community, and the very first book on lesbian health matters that was written as another bit from the Boston Women's Health Collective. So those are some basics, but there has been research that's been done for a long time that just hasn't been out into the general public.
Did you say belly dancing is Natural.
Essential.
Yeah, it's called Dance of Birth, Belly Dancing as Natural Childbirth Conditioning, right?
That's
So the
not-
reason for belly dance actually wasn't for, the male gaze. It was actually a women's mystery rite in terms of learning how to control contractions
That's
and to
awesome.
strengthen the belly muscles.
So
So
interesting.
it's one of the things that we actually teach a lot in lesbian community.
That's awesome. Thank you for sharing that.
I'm putting it in here too.
Mhm.
Had to run and go get some. That one, that one. Any other questions? We're still recording, folks.
Yeah, I thought it was Dr. Rambarran. I thought you presented that very nicely, succinctly. Great information throughout. I really appreciate the information you gave us.
Oh, thank you.
In terms of for HIV and PrEP, like in Barbados, what has been the perception of PrEP, and like have you all been having to do campaigns to target people, or has medical providers been a source for people to be getting on PrEP?
Oh, good question. Actually, we just published online open access our first year experience with PrEP provision in Barbados. It is being supplied, but PrEP is free here. And it's being supplied by the government, as in at a government center, which is actually the treatment and care center for HIV. And it's also being provided by Equals, which is LGBTQ plus NGO. So like a dual kind of system. And when Equal started providing it, they didn't have to do a lot of sensitization apart from just posting on social media, PrEP is available, because a lot of especially men who had sex with men, were already aware of it. And, through their social networks in the global north, and some were already even on it, having imported it. So we didn't have to do a lot of sensitization that way. What we found is that with everybody else we do, like women, and other partners, non-LGBTQ plus people in serodiscordant relationships, they didn't know about it, and we were planning to expand, but then COVID happened, and we had stock out of PrEP, we had stock out of testing. It was a mess. So and we still haven't really recovered with that. So as well, PrEP Equals was being funded by USAID PEPFAR, and they have also come out of the region. So now Equals can't do the large scale sort of, awareness campaign dissemination they were hoping to do. So it's trucking along, but it's not being used as well as it should. Any other questions, comments? Sling me them.
Sling you?
Yes, sling them my way, man.
Ah. All right, I'm going to stop the recording.